Hi class, Dr. Pipe here. We're going to go over renal and urinary tract. Renal, genital, urinary. Let's go over some structure and function overview. We have the kidneys. The right is slightly lower than the left due to the placement of the liver. Kidneys are surrounded by the renal capsule and embedded in a mass of fat and covered with renal fascia. There's medial indentation, there's the hilum, this is where the blood vessels, nerves, lymphatic vessels, and ureter enter and exit the kidney. The cortex is the outer layer of the kidney, and this contains all the glomeruli, most proximal tubules, and some segments of the distal tubule. The medulla forms the inner part of the kidneys and is consistent with pyramids. The renal columns extend from cortex down between the renal pyramids. The major calyces receive urine from collecting ducts through the renal papilla. The major calyces join to form the renal pelvis, which connects with the proximal end of the ureter. There's the walls of the calyces, pelvis, and ureter are lined with epithelial cells and contain smooth muscle cells that contract to move urine out of the bladder. Move urine to the bladder. The nephron, this is the functional unit of the kidney. This forms a filtrate of protein-free plasma. Each kidney contains about 1.2 million nephrons. There's three types. There's superficial neurons, which are 85% of the neurons, midcortical, and juxtamedullary. The glomerulus, there's a tuft of capillaries that loop into the circular Bowman glomerular capsule, or the Bowman space, and the glomerular filtration membrane. This filters selected blood components through the three layers. Structure and function, more there. There's the ureters. The urine is funneled from the renal pelvis into the ureters. Each ureter is about 30 centimeters long. There's downward peristaltic activity that propels urine into the bladder, and contraction of the bladder during micturition compresses lower end of the ureter and prevents reflux. The bladder and urethra. The bladder is a bag, and it's composed of smooth muscle fibers that form detrusor muscles and its smooth lining of transitional epithelium. The urethra extends from the inferior side of the bladder to the outside of the body. Internal and external urethral sphincter control. There's excretion of urine from the bladder through the urethra. The female urethra is 3 to 4 centimeters, and in the male, it's 18 to 20 centimeters. Renal blood flow, the kidneys are highly vascularized, and they receive 20 to 25% of cardiac output. Glomerular filtration rate, this is the filtration of plasma per unit of time. And this is directly related to the perfusion pressure in the glomerular capillaries. GFR is directly related to the renal blood flow, which is regulated by intrinsic autoregulatory mechanisms, neural regulation, and hormonal regulation. Kidney function, the major function is urine formation and involves filtration, reabsorption, and secretion. The function of the nephrons, and the fluid is filtered at the glomerulus. Nephron filters plasma of the glomerulus and reabsorbs and secretes different substances at various parts of its tubular structure. The function of the nephron is to form a filtrate of protein-free plasma. Glomerular filtration, the fluid is filtered by the glomerular capillary filtration membrane and is protein-free, but contains electrolytes such as sodium, chloride, and potassium, and organic molecules such as creatinine, urea, and glucose. Urea is the end product of protein metabolism and is the major constituent of urine along with water. Catecholamines in response to hemorrhage or ECF depletion, extracellular fluid depletion. The sympathetic neurons release norepinephrine. and the adrenal medulla releases epinephrine and norepinephrine. We have the antidiuretic hormone, and the concentration of the final urine is controlled by the antidiuretic hormone. Tests of renal function. A number of specific renal function can be measured by renal clearance. GFR is the best estimate of functioning of renal tissue, the glomerular filtration rate. Paramniohippuric acid, or PAH, shows effective renal blood flow. Plasma creatinine concentrations, a long-term decline in GFR over weeks or months can show here. Blood urea nitrogen, this is the concentration of urea nitrogen in the blood, and this reflects glomerular filtration and urine concentrating capacity. Normal range is 10 to 20. BUN levels increase as glomerular filtration drops. BUN increases with dehydration and with acute or chronic renal failure. And BUN level varies as a result of altered protein intake and protein catabolism, which is a poor measure of GFR. Urinalysis looks at the urine color, pH, specific gravity, and urine sediment will look for RBCs, CAS crystals, and WBCs. Okay, let's look at some alterations of renal and urinary tract function. There may be upper urinary tract obstruction. This can be caused by stricture, calculi, ureteral compression from the vessel, tumor, or abdominal inflammation or scarring, such as retroperitoneal fibrosis, and malignancy. Obstruction, this can cause dilation of the ureter, renal pelvis, calyces, and the renal parenchyma. Kidney stones, calculi, also known as nephrolithiasis or calculi. These are masses of crystals, proteins, and other substances. These can be found and occur in the kidneys, ureters, and bladder. Risk factors include age, gender, race, geographic location, seasonal factors, the amount of fluid a person intakes, diet, occupation, and genetic predisposition. Conditions such as urinary tract infection, hypertension, atherosclerosis, metabolic syndrome, obesity, and diabetes. Patients all have a higher incidence of kidney stones. Can have a higher incidence of kidney stones with these disorders. Types of stones, most are calcium oxalate or phosphate, which account for about 70 to 80%. You have struvite, which consist of magnesium, ammonium, or phosphate. And that's about 15% of stones. Uric acid, about 7%. Cysteine, which is rare and less than 1%. Clinical manifestations: patient may have renal colic, flank pain that's radiating to the groin, nausea and vomiting, or hematuria. And here's a picture of different kidney stones. Lower urinary tract obstruction, patient may have neurogenic bladder that causes this. And this is bladder dysfunction that's caused by some sort of neurological condition. Overactive bladder. This is a chronic syndrome of detrusor overactivity and the absence of infection. This is characterized by urgency with involuntary detrusor contractions during the bladder filling phase. Symptoms: they have a syndrome of urgency, with or without urge incontinence, and usually it's associated with frequency and nocturia. Lower urinary tract obstruction, obstructions to urine flow. This can be caused by urethral stricture, prostate enlargement, pelvic organ prolapse, partial obstruction of the bladder outlet or urethra. You can have tumors that cause this: renal tumor, renal adenomas, which are benign, renal transitional cell carcinoma, renal cell carcinoma, which is the most common renal neoplasm. Bladder tumor, urothelial or transitional cell carcinoma can occur in the bladder. Renal cell carcinoma, this is 85 to 90% of all renal neoplasms are this type. This occurs 2 times more often in men than in women. Age of onset is usually 50 to 60 years of age. Blacks have a higher incidence and mortality from this type of cancer. Risk factors include cigarette smoking, obesity, hypertension, and advanced stage chronic renal failure. Cigarette smoking is attributed here because nicotine goes through the system and goes through the kidneys for filtration, comes out the bladder, so that exposure to the nicotine can lead to renal cancer. Clinical manifestations: patient may have hematuria, dull aching flank pain, or palpable flank mass. Systemic manifestations, usually with advanced stage of disease, the patient may have weight loss, fatigue, intermittent fever from the tumor cytokines, anemia from hematuria and lack of erythropoietin, polycythemia from tumor secretion of erythropoietin, hypertension from elevated renin levels, or alterations in LFTs or liver function tests. Urinary tract infections, UTI, this can occur in the urethra, bladder, ureter, or kidney. Acute cystitis, this is inflammation of the bladder. This is the most common UTI, and it's more common in women because of that shorter urethra. Most bacteria are E. coli coming from the rectal area. That's about 80 to 85%. Staphylococcus, about 10%. Less commonly, Klebsiella, Proteus, Pseudomonas, fungi, viruses, parasites, and tubercular bacilli can also cause cystitis. Clinical manifestations: patient may complain of frequency, urgency, pain with urination, suprapubic pain, low back pain, hematuria, cloudy, foul-smelling urine, and they may have flank pain. There's painful bladder syndrome or interstitial cystitis, which is a possible autoimmune reaction that should be considered in the differential diagnosis in a patient with suspected cystitis. Acute pyelonephritis, infection of one or both upper urinary tracts, such as the ureter, renal pelvis, or kidney interstitium. Pathogens involved here, again, E. coli, Proteus, Pseudomonas, and the latter two are more common after urethral instrumentation or surgery. Clinical manifestations: patient may present with acute onset, fever, chills, flank or groin pain, and symptoms characteristic of a UTI. The urinalysis may show WBC cast. Chronic pyelonephritis: this is a persistent or recurrent infection of the kidney leading to scarring. One or both kidneys may be involved. Clinical manifestations: early symptoms are minimal, commonly include frequency, dysuria, flank pain, and hypertension. Progression of disease leads to renal failure. There's inability to conserve sodium with loss of tubular function, and the patient may develop hyperkalemia and metabolic acidosis. Acute kidney injury. This could be acute and rapidly progressing within hours. This may be reversible. Renal insufficiency, renal failure, and uremia or azotemia show decreasing renal function. A sudden decline in kidney function with decreased glomerular filtration and accumulation of nitrogenous waste products in the blood, and you might see an increased BUN and creatinine. Clinical progression is in 3 phases. There's initiation, the maintenance or oliguric phase, and the recovery phase. Acute kidney injury, more there causes. There can be pre-renal, intrarenal, or post-renal. Pre-renal causes hypovolemia, hemorrhagic blood loss, loss of plasma volume, water and electrolyte losses, hypotension or hypoperfusion, septic shock, cardiac failure or shock, pulmonary embolism, stenosis of the renal artery, and increased intra-abdominal pressure are all considered pre-renal causes. Intrarenal ATN, acute tubular necrosis, glomerulopathies, acute interstitial necrosis, vascular damage, malignant hypertension, coagulation defects, renal artery vein occlusion, and bilateral acute pyelonephritis. Post-renal causes, obstructive uropathies such as fibrosis, ureteral destruction from a tumor, edema, stones, or clots, and bladder neck obstruction or neurogenic bladder. Here's just some other different causes comparing those there. Chronic kidney disease, this is the progressive loss of renal function and is associated with systemic diseases such as hypertension, diabetes, lupus, intrinsic kidney disease such as stones, acute kidney injury, chronic glomerulonephritis, chronic pyelonephritis, obstructive uropathies, and vascular disorders. The National Kidney Foundation considers kidney damage as GFR less than 60 for 3 months or more, irrespective of the cause. Patient may have azotemia, which is increased levels of serum urea, creatinine, or other nitrogenous compounds. May have uremia, which is a pro-inflammatory state with many systemic effects and known as the uremic syndrome, and is associated with accumulation of urea and nitrogenous compounds of toxins and toxins. Symptoms, patient may be often asymptomatic, may have hypertension, anorexia, nausea, vomiting, either diarrhea or constipation, malnutrition, weight loss, pruritus or itching, edema, and anemia. Stages of chronic kidney disease here on this chart, and the systemic effects of chronic kidney disease and uremia all to be considered there. Okay, we'll look at alterations in renal and urinary tract functions in children. Structure and function of the urinary system in children. Embryonic urinary system develops as 3 sets of sequentially replaced organs: the pronephros, mesonephros, and the metanephros. The Wilms tumor 1 or WT1 gene plays an important role at all stages of kidney development and maintenance of kidney function. Urine formation and excretion begins by the 3rd month of gestation, and this contributes to the amniotic fluid. Fluid and electrolyte balance. Renal distribution of blood flow during your newborn period is primarily in the renal medulla. Higher blood flow and shorter loops produce more dilute urine. Immature kidneys are less responsive to the antidiuretic hormone. Urea excretion is low due to high anabolic state and use of protein for growth. There's a narrow chemical safety margin. The percentage of extracellular fluid volume of the newborn infant is nearly double. There's a greater rate of fluid exchange, and electrolyte concentration in the ECF is greater in the newborn than in the adult. Alterations in renal and bladder function in children, some congenital abnormalities that can occur. Baby may have a U-shaped horseshoe kidney. They may be asymptomatic with this. The common problems seen are hydronephrosis, infection, stone formation, and tumors. Hypospadias, where the urethral meatus is located on the ventral side or the undersurface of the penis. Epispadias is where the dorsal urethra is not fused and has failed to form a tube. The urethral opening is on the dorsal surface of the penis. Extrosophy of the bladder. This is a rare extensive congenital anomaly of herniation of the bladder through the abdominal wall with failure of the abdominal muscles, pelvic ring, and pelvic floor musculature to fuse in the midline. Uretopelvic junction obstruction. There's blockage of the tapered point where the renal pelvis transitions into the ureter. Intrinsic malformation of smooth muscle hypertrophy and fibrosis produces obstruction in 90% of the cases. More on alterations, bladder outlet obstruction. This is rare and include urethral valves, urethral polyps, and urethral atresia. Hypoplastic and dysplastic kidneys during embryonic development of uteric duct growth into metanephric tissue. There's a triggering formation of kidney, and if growth doesn't occur, the kidney is absent, or it's called renal aplasia. Hypoplastic kidney, their kidneys are small with a decreased number of nephrons. And renal dysplasia, abnormal differentiation of renal tissues. Renal agenesis, there's an absence of one or both kidneys. Unilateral renal agenesis, males are more often affected. Bilateral renal agenesis, also known as Potter syndrome. This is not compatible with extrauterine life. Polycystic kidneys, autosomal dominant polycystic kidney disease. This is an inherited disorder, and there's mutations of PKD1, chromosome 16, and PKD2, or chromosome 4. There's defects in the formation of epithelial cells, and cilium results in cyst formation and obstruction fibrosis, and there's loss of functional renal parenchyma. Cysts may also occur in the liver, ovaries, and pancreas. Hypertension, heart valve defects, cerebral and aortic aneurysms may occur with the polycystic kidneys. And here's looking at the normal kidney and the polycystic kidney. Okay, bladder disorders, UTIs. This is the colonization of bacteria anywhere along the urinary tract. Mostly it's perineal bacteria from E. coli. Cystitis is when the infection is in the bladder and results in mucosal inflammation and congestion. Symptoms, infants may have vomiting, diarrhea, or jaundice. And infants and young children may have fever only, or they may have frequency, urgency, enuresis, or incontinence. Acute pyelonephritis, they may have chills, fever, flank or abdominal pain, and chronic pyelonephritis may be asymptomatic. Vesicoureteral reflux. This is the retrograde flow of bladder urine into the kidneys, ureters, or both. Reflux allows infected urine from the bladder to the kidneys, and this can cause pyelonephritis as that urine is able to get back up to the kidneys. Urinary incontinence. Involuntary passage of urine by a child who is beyond the age with voluntary bladder control should have been acquired. Enuresis, this is nighttime bedwetting. Functional incontinence is urinary incontinence in which no structural or neurologic abnormality can be identified. Organic causes include UTIs, neurologic disturbances, congenital defects of the meatus, urethra, and bladder neck, allergies, constipation, and obesity. And this is just a diagram indicating the vesicoureteral reflux grades. Glomerular disorders, glomerular nephritis, proliferation and inflammation of the glomeruli are secondary to an immune mechanism. Sudden onset, patient may have hematuria with RBC casts and proteinuria. And this may be accompanied by renal salt and water retention, edema, hypertension, azotemia, and decreased glomerular filtration rate. Acute post-streptococcal glomerulonephritis. This is one of the most common immune complex mediated renal diseases in children 5 to 15 years of age and is representative of acute glomerulonephritis. There's immune complexes that initiate inflammation, and this often occurs after throat, pharyngitis, or a skin impetigo infection with nephrogenetic strains of group A beta hemolytic streptococci. Symptoms begin 1 to 2 weeks after an upper respiratory infection and up to 6 weeks after a skin infection. Urine is usually smoky brown or cola colored, may have flank or mid-abdominal pain, irritability, general malaise, and fever. Acute hypertension may cause headaches, vomiting, somnolence, and other CNS manifestations, including seizures. Glomerular disorders, the Hemlock-Schönlein purpuranephritis. This is an immune-mediated IgA vasculitis that affects glomerular blood vessels, causing inflammation and damage to the vessel wall. Classic symptoms include palpable purpura, arthritis, abdominal pain, and renal disease characterized by gross or microscopic hematuria with mild or no proteinuria. And this is a risk for chronic kidney disease. Hemolytic uremic syndrome, an acute disorder characterized by microangiopathic hemolytic anemia, thrombocytopenia, and renal impairment. Most common community-acquired cause of acute renal failure in young children, and this occurs most commonly in newborns and children 4 and younger. And this is associated with bacterial and viral agents. Nephrotic syndrome is a symptom complex characterized by proteinuria, hypoalbuminemia, hyperlipidemia, and edema. It can be primary or idiopathic, which has no identifiable cause, or secondary that results from systemic disease or other causes, such as drugs, toxins, diabetes mellitus, and lupus nephritis. Onset is insidious, may have periorbital edema that may be the first sign, scrotal or labial edema, and may have frothy urine. Kidney injury, acute or chronic kidney injury in children is rare. Pre-renal acute kidney injury can be caused by dehydration, hemorrhage, and sepsis. Intrinsic AKI, glomerulonephritis, hemolytic uremic syndrome, and hypersensitivity reactions to drugs or infectious agents. Post-renal acute kidney injury can be caused by obstructive neuropathies, such as posterior urethral valves and obstruction of the uretero-pelvic junction. Chronic kidney failure in very young children is commonly associated with congenital renal structural abnormalities. And finally, we'll go over Wilms tumor. This is an embryonal tumor of the kidney arising from epigenetic and genetic changes that lead to abnormal proliferation of renal stem cells. This is a nephroblastoma, and is the most common solid tumor in children. 1 to 5 years of age, and the peak incidence is 2 to 3 years of age. There's sporadic and inherited origins, and this does only affect one kidney. Clinical manifestations, there's enlarging asymptomatic upper abdominal mass in a healthy, thriving child, which is about 90%, and may also have vague abdominal pain, hematuria, fever, and hypertension. Just please keep in mind that I've only covered a portion of the information from these chapters. Students are responsible for reviewing and reading the entire chapter. Please let me know if you have any questions. Thank you for your time and happy learning.